So can I just invite the three speakers to come up on the podium, please? And I know you guys heard a lot of different things. We try to have themes that are relevant to a general orthopedic surgeon, especially interested in trauma. So I just open it up for any questions, comments for any of the talks, or if you have any other questions related to pediatric orthopedics, we'll take a stab at it. Any questions? Yep.
From anyone in the community to do any pediatric orthopedics, particularly trauma, forget it, because children's is right down the road. Is that a good thing or is that a bad thing?
That's a very politically charged question.
Yeah, I mean, should we be doing pediatrics out in the community or just send it all downtown?
I think and I'll take a stab at it and then we'll open it up. I think the PC answer is depends on your local community, relationships, et cetera, et cetera. I mean, we did a study when I was in the East Coast, just looking at what came to our level 1 trauma center, inner city, from the community. And I forget the exact numbers, but I think 85 to 90% were undisplaced or minimally displaced distal radius fractures, which can be treated, by a PGY 1 or 2. So I think, and some of it, the initial issue was, well, are these under or uninsured patients? And the honest truth was, that's not always the case. I think it goes back to the comfort level, litigation issues, concerns, et cetera. I mean, what do you guys feel? Anything different?
I would just say the same, like comfort level. So if you feel like you're going to do a good job, I don't know that there's really a reason to, but obviously, depending on what your relationship is, you wouldn't want to impact that when you actually really need help.
Thank you.
Yeah, but I would just, I don't know if that really answered your question, but I feel like, personal relationships, and that goes both ways, right? A pediatric orthopedist with an adult partner and vice versa, I think that's key. And then you have to deal with the marketing forces, et cetera. But I think like anything else, if you don't use it, you lose it. So I would say there's nothing very fancy about treating broken bones, and you guys are experts, so I don't think you should shy away from treating them.
Thank you.
Question for Dr. Chan. Do you recommend using parallel pins or diverging pins? And sometimes when the slip is pretty severe, I'm just wondering, you can't really get a parallel pin in.
Yes, so it depends on how severe the slip is. And obviously you want to get parallel, or perpendicular rather, to the physis, but if it's a severe slip or if it's a valgus slip, then you're not going to be able to do that. So sometimes being a little bit oblique is fine too. Okay.
And for Dr. Gippard, I wasn't sure I understood with the ultrasound, you're looking for joint space narrowing. I thought it was widening that you're worried about.
That may have been a typo. Looking for a fusion on the ultrasound.
Okay, but it's on an X-ray, it'd be a widening of the joint?
Widening.
Okay.
Can I take a stab at the Skiffy question for the pins? So I think if you're using a big enough screw, it's exceedingly hard to get 2 good screws in. So that should be your focus, not on whether they're parallel or divergent, and you want them not to be in the articular surface. So my approach to it is 1 really good pin, and if you can get another one in somewhere, great. If not, you have 1 really good pin. So even, I'm older than they are, also add, but the goal is to get 1 really good perpendicular screw in with as many threads across as possible, and I wouldn't try and focus on 2. Priority would be 1 good one in the joint, not in the joint.
You ever find that you have to use a derotation pin first before you put the screw in? Okay. And then just one more thing, general observation or query about not just pediatric orthopedics, but adult trauma orthopedics. They've developed a program for children with ADHD when they get their license, because they found that there's a 300% increased risk of accidents. And I'm just wondering if the Pediatric Orthopedic Society has looked at educating the families about safety techniques for their children that have ADHD, and whether we shouldn't be doing the same thing with adults.
Yeah. Well, I know, I mean, there's this big thing, even with the Academy and POSNA, about play safe and safe playgrounds, et cetera. I don't think, as far as I know, that POSNA has anything just for ADHD kids, but I tell you, these days, every other kid is, so wired up. And half of them are on some kind of medications too. So I think it's more than just a very small population. But I'll bring it up to POSNA when we go for the meeting in a couple of months.
We don't need a license to become adolescents.
There you go. All right. Thank you. Good question.
Hi, Tim Bray. I'm a traumatologist, and we take care of all the pediatric trauma at our center. We don't have a children's hospital. Our town is about 500,000. I think it's probably over 1 million, the referral. I mean, it's not Boston, but we teach pediatric trauma. We take care of pediatric patients, and I think there's data to suggest that adults taking care of pediatric trauma do at least equal to what the pediatric orthopedists do. So anyway, I'm all in favor of you taking care of your patients.
Yeah, good, nice. Thank you. But I tell you, just anecdotally, I had in my prior practice a very smart, efficient, well-trained adult orthopedist, and somehow he was like so nervous if somebody was under 16, he would just not touch him. So I think some of it is psychological and very individual. I think we've got maybe 5-ish minutes more. I'm going to pick on our partners here. So Dr. Hill, if, let's say, somebody's out in the community, non-pediatric orthopedist, has a type 3 supracondylar with a questionable vascular issue, skin's puckered, what should the approach be? Like, should they transfer? Should they reduce? Should they operate? What should they do?
So I would consider 2 factors. One is just the surgeon's comfort level. So if they're not comfortable with it, then the approach for the reduction or the open approach, then I would transfer it. And then even if you are comfortable, what are the resources in case there needs to be a vascular repair if you're not able to perform that yourself? So if you are in a situation where you need help with the vascular injury and there's no one on call that is comfortable enough to take care of a pediatric vascular injury, then I would recommend transferring it. But if all of those criteria are met at your institution, I think it's safe to keep them there.
All right, great, thanks. And then for Dr. Kephart, you talked about septic arthritis, et cetera. Now, we see a fair amount of MRSA, some places more than others. Is there anything different when, a child has a MRSA infection that you could sort of think about initially and say, hey, this could be MRSA, and do you do anything different?
I mean, I think one thing would be helpful to counsel the family to expect a longer treatment course, perhaps the need for reoperation, comorbidities like DVTs, need for longer antibiotic treatment. It's a different entity.
Good, perfect. And then for Dr. Chow, can't leave you alone. Let's say again, you're in the community, and or maybe you're not in the community, you're in a children's hospital. What's your take on a child who has an unstable SCFE? Because we hear all the time, timing is of essence for an unstable SCFE or acute femoral neck fracture. So is there an urgency to do it? Let's say a child comes in the afternoon, the NPO status isn't going to be clear till 9 or 7 in the evening. What would you do? Would you operate the same night or the next day?
I think it depends on the resources you have at the hospital. If you have a full team, then ideally getting to an unstable slip within 24 hours, I think would be best. But if the patient's made bed rest, I think you can wait until you get a full team in the morning. And so it's not an emergency like a femoral neck fracture per se, because there is still periosteum and perichondrium around the head-neck junction. But the more risk or more chance of it displacing, the higher risk it is for the patient to tear the retinacular vessels.
Great, super, thank you. All right, I think we're done with this session. Thanks, everybody.